Indeed, here, my solution would have been treat the patient with an appropriate and approved TRK inhibitor. Of course, you could consider a treatment within a trial with another TRK inhibitor. And I think those data would be supported by the NCCN and ESMO guidelines, among others. You see here what happened after 2 months of treatment with entrectinib, which is the one of the approved drugs in our country, but the only one reimbursed. You see here a clear improvement of the lymph node on the left is much higher, 3.5 centimeters to less than 2 centimeters here on the right picture of the CT scan done in October. If we go to the next slide, I like to show here those agents that are available for a number of years now, larotrectinib and entrectinib, both approved in my country. You see, larotrectinib is a really specific inhibitor of the NTRK genes, and as you see here in this kinome inhibition panel, entrectinib is also a very good TRK inhibitor, but you see that is also affecting some other kinases at the same concentrations as well. You see, this agent has shown clear activity in preclinical models, but also we have robust data in the clinical scenario. The initial trial with the larotrectinib resulted in response in about 2/3 of the patients with non-small solid tumors, looking specifically on those patients with non-small cell lung cancer. Of course, you see responses again in about some, I would say, in greens here, about again more than 60% of the cases. PFS was about 31 months, being 22 months for those patients with NTRK tumors. And I think that number is pretty important. Indeed, you go to the next panel, you see what happened with entrectinib. Again, very nice responses, more than 60% in the solid tumors, being about 62% in those 41 patients here included with non-small cell lung cancer. Duration of response was 27 months. I remember the overall PFS was about 16 months. That may be a bit less across trial comparison as compared to larotrectinib. Going a bit more in detail on the larotrectinib trial, you see here that some 32 patients were included. Most of them had adenocarcinoma. Even, as I mentioned, some patients with squamous cell carcinoma may have these fusions. 40% of the patients had some brain metastases, and most of them were heavily pretreated, some of them with more than 2 or 3 prior lines. You see here that responses were seen in a good number of cases. In this particular study, 24 patients out of 32 had fusions affecting NTRK1, 9 patients NTRK3, and actually in one case, both fusions were specified. You see responses in some 2/3 of the cases, 66%, with slight variations, more frequent, with the better PS and with less prior lines, but specifically very consistent magnitude of responses across the different populations studied. Median duration of response was in the range of 3 years, 34 months. Median PFS, nearly 2 years, 22 months. And median OS was 39 months, nearly 4 years. So I could say the data pretty impressive altogether. We have some data regarding mechanism of resistance in 18 patients. In most of the cases, we detected a non-target mutations, particularly on the solvent front region, that was affecting some more than 80% of the cases. In 2 cases, 11% had off-target mechanisms of resistance, affected BRAF mutations or MET amplifications, I have to say. And you see here that some novel NTRK uh, inhibitors are available with nice responses, even in TKI pretreated patients, responses in some 45% of the cases treated with selitrectinib or repotrectinib. On those patients treated with repo with uh, TKI naive disease, responses were a bit higher, nearly 60%, and the same number, the same proportion of patients responded of those with solver fraud mutations. Again, with ICP 723, responses were seen in two-thirds of the cases, 66%. And importantly, at the ASCO, we have seen data with thorletrectinib in some 49 patients treated, heavily pretreated before being included in the trial, and responses were observed in 84% of the cases. And I think those data are also to be taken into account. So just let me finalize with some take-home message. I think NTRK fusion are rare in non-small cell lung cancer, but frequent, actionable, and actually the result with available agents are pretty good responses in more than two-thirds of the cases, typically long-lasting, including intracranial activity for most of the cases. The safety profile is relatively mild, I would say. Novel agents are now available with activity in TKI pretreated patients with different profile of activity, but also of safety. And I think those data will help us to choose among the agents that are coming for the near future. This is everything I have to say today, and I then hand the virtual podium to Dr. Gaynor. Justin?